Good afternoon, everyone, and thank you for joining us for this panel discussion on the science of coronavirus transmission. When COVID-19 first emerged at the start of this year, which feels like a very long time ago, not much was known about how this virus spread or whether it could even pass between humans. 27 million cases later, we now know for sure that this is a disease that spreads all too easily from person to person, and of course the consequences have been absolutely world-changing. But the science of how this disease spreads is still evolving. Microbiologists, virologists, engineers, and public health experts alike are responding to new findings and studies every day. The key public health messages that we have been hearing that are designed to stem the spread of the disease all remain. Wash your hands, wear a mask, keep your distance. But there are now many other factors to consider. Are we safer indoors or outdoors? Is the virus airborne? Should we be washing our groceries, touching our faces, going to school, going to the office? To consider these questions and many more, we're joined today by a panel of experts from across the UK. We have Dr. Conor Bamford, a virologist at the Queen's University Belfast, who studies how our immune system defends us against viruses such as SARS and COVID-19. We have Dr. Lena Sirik, a professor of environmental engineering at UCL in London, who researches how microbes such as viruses move around in indoor spaces. And we have Dr. Andrew Lee, a reader in global public health at the University of Sheffield, an expert in communicable disease control. I'm going to have to say that word a lot this webinar, so do bear with me. I'm Megan Clement, an editor at The Conversation working on coronavirus. And we're going to kick off soon, but just to let you know that if you have any questions for our panel, you can put them in the comments stream and we'll try to get to them at the end. So welcome to all our panelists. Thank you very much, everybody, for joining us today. I want to start with Conor in Belfast, because Conor, you wrote the very first article about COVID-19 that appeared on theconversation.com way back in January about this mysterious pneumonia that was emerging in China. Can you maybe start today by telling us what we have learned since then about what makes SARS-CoV-2 spread so effectively compared to other diseases that maybe you've looked at?
Yeah, so I can try and attempt to sort of summarize these findings in a sort of a short space of time. So I think in the last few months, or the last 9 months, we've actually learned a tremendous amount about the virus, the disease, and how it spread. And I sort of want to bring everyone back to sort of what it was like in January. So we'd only known about a handful of cases. These were clustered in Wuhan. They were the most serious cases, and we had an idea that they were caused by a coronavirus. And this was really scary because we actually thought it was going to be SARS all over again. And what turned out to be the case was actually it was far worse than what what we were actually sort of not hoping for, what we had predicted. During this phase, I think one of the things that characterized it is actually we grossly underestimated the scale and the potential damage that this virus can do. And a part of that is actually due to how transmissible it was. So we know at that stage, even though we were focused on these cases in Wuhan, the virus had probably already spread sort of silently across China. It was sort of spreading out into across Asia. And then, of course, we saw these very large epidemics in Europe and the Middle East, and then the Americas and South Asia now. And I think, as we're all sort of emerging out of lockdown, we're sort of trying to think and trying to learn how we can sort of cope with this transmissibility of this disease. Based on the science, or what the main things we've learned, and I think we've learned, we kind of have an idea about the origin of this virus. We think that at some point it came from a bat, and it probably did so, or at least crossed that sort of barrier sort of towards the end of last year. A defining feature of this virus and what impacts the transmissibility is that actually most cases are mild and they don't really show that many symptoms. The virus spreads tremendously well, not as well as some of the classic viruses like measles, but still well enough and still clearly enough to be a major global health threat. In terms of immunity, we know that we do get some immunity, but we aren't sure how long that lasts. And another major thing in what science is trying to do is come up with treatments and vaccines, and we're making a lot of progress to that. And in your opening bit, Megan, you asked about sort of comparing it to SARS. So I think that this virus is clearly not SARS, the original SARS. It is a close cousin of SARS, and that's why we call it SARS-CoV-2. And the disease seems to have a similar presentation. But what's really different is actually how this virus transmits, and that's been the real issue here. And so on one hand, the virus is not as deadly as SARS-1, and it's all these mild cases that are causing the problem, and it's much more transmissible. But it's the combination of the transmissibility in relative terms to the disease that makes it so difficult. In that with SARS, you were most transmissible when you were at peak symptoms and you were really quite sick, and you were probably in hospital in isolation. Whereas with SARS-CoV-2 and COVID-19, you're probably most transmissible just before you have symptoms, or maybe you don't really have that many symptoms at all. And I think this is what it makes this virus so difficult, and this is what's sort of really been defining the pandemic as a whole. So I think that's my attempt to try to summarize it all.
I was muted, sorry. That's really interesting. The fact that this, in most cases, is quite a mild disease means it transmits easier because we are going about in the world and giving it to other people if we have very few or no symptoms. Can you sort of, going on from that, Connor, can you explain, because I know you're an expert in the immune system, what happens? So we have, you say we come into contact with somebody who is asymptomatic or has mild symptoms or even severe symptoms, and we inhale the SARS-CoV-2 virus ourselves. What then happens in our bodies? How do we get from the transmission, which is the subject of this discussion, to infection with the disease?
Yes, so this is where we're really interested in how this process comes about, and it sort of underpins how we can make better treatments and make better vaccines. And it's still quite unknown, but we are beginning to piece together a couple of the different parts of the puzzle. And first of all, the virus, it's the disease, and the whole thing is mainly focused around the respiratory tract. So it's not just the lungs, but you can even think of it as the eyes, the back of the nose, the throat, all the way down sort of into the lungs. So the virus will get in there somehow, whether it's through touch, large droplets, smaller droplets. It will get in there, and it will latch on to the cells that line your whole respiratory tract, and are really likely cells that it can infect them and make thousands, hundreds of thousands of new copies of viruses that will continue this infection, and you'll have lots of virus built up in your upper respiratory tract. And in most people, this is the virus that's being transmitted, but in most people, they won't really get that many symptoms. However, the virus can cause a little bit of damage to those cells, and it also causes some inflammation, and this is probably what results in people feeling those mild symptoms. In some people, the virus can spread from the upper respiratory tract down and further into the lung, into the smaller airways. And this is where it causes the real damage. This is where it can hurt the cells that are trying to bring in oxygen to the cell, into the body. And the cells are trying to get rid of waste products like carbon dioxide. And if it hurts these, and if it can hurt the cell by directly impacting them, or it can cause inflammation, and if it causes this, it can lead to damage, and that's what makes you not be able to breathe, and that's what's the clinical issue with this virus. There's also some sort of systemic involvement in that the virus, we can find it in the circulation, and we can find it in the kidneys, and we aren't really sure how it gets there, but it does get there, and there's definitely a systemic component. There's also a GI tract component, so the virus can get into and replicate in your gastrointestinal system, and it probably gets in there sort of you swallowing the virus from the virus that's in the back of your throat, and it can survive in your stomach, and it's probably able to replicate in your gut. And that's why people you shed an awful lot amount of virus and virus particles into your stool, and this is what we could track through sort of wastewater analysis as well. Another feature of the disease is that it's not just all about death. There's, even if you have a mild COVID-19, there's still, a tremendous morbidity to this. And there's also this idea that if you are severely infected, there's this long COVID. So you might not have died, but you had a very serious bout of pneumonia, and you're going to take a very long time to get around this. Understanding a defining feature of this is that actually that it seems to be defined by comorbidities. Most people will remain not that sick, but the people who are at most at risk are those who are elderly. And again, we don't really know why this is the case. But we were trying to figure that out. And also there's some other comorbidities that you can predict, but also there's just the seemingly random effect that even in people who are young and healthy, and they might have some sort of genetic predisposition to a severe SARS-CoV-2 infection and COVID-19 that we don't really know about.
Yeah, there's still so much we don't know about this disease and what it does to us. And I think we're really going to wait and see how these cases of long COVID turn out. But they are absolutely terrifying, and they really show us that nobody is safe from this. We're going to come back to some of the points you make, Connor, about asymptomatic and mild symptomatic people and transmission. But I want to move to Lena now. Lena is a microbiologist, and I know that you look at sort of how pathogens like viruses move around in particularly indoor spaces. So in terms of how the coronavirus or SARS-CoV-2 moves around in a space, early on in this pandemic, I remember really, really well, I was sort of going to the supermarket and coming home and like plunging all of my groceries into a sink and scrubbing them and terrified about touching my face. It does seem like we've moved on a little from that at this time of the pandemic. Can you talk a bit about how the science has sort of evolved in terms of our understanding of how this spreads on surfaces, say supermarket goods, or just in the air, which I know is a big point of debate at the moment?
Yes, absolutely. So I think initially when we first encountered SARS-CoV-2, the thinking was that it definitely wasn't airborne. Therefore, it's all about close contact and about touching surfaces, coming into contact with it, and then transferring it to your face. And of course, that at that point, we were pretty sure that larger droplets, so larger respiratory droplets, which we might cough out or sneeze out or talk out or sing out, would also cause the disease. But the small droplets at that point were ruled out. Pretty early on during as the pandemic was taking off, some research was done looking at how long the virus survives on various surfaces. So some researchers looked at plastics and cardboard and also stainless steel and so on, and many more surfaces have been explored since, and it was found that the virus could survive for a few days. So I think we were initially worried that there'll be lots of this virus everywhere, but really I think ultimately that is still a threat. It's just that really there needs to be a critical mass of the virus on surfaces for it to cause an infection. Not that we know what that critical mass is, and I guess we'll probably revisit that later on. So surfaces are still certainly something to think about and something that we need to be careful about, especially if they are high touch surfaces that you might encounter in public spaces, like on public transport, or if you're at work and you're in the toilets at work, that these are places where everyone goes at some point during the day and will touch different surfaces and so on. We also now have a pretty good idea about how to eliminate the virus. So, I mean, it's fairly susceptible to the usual cleaning methods that we use. But, clearly it's still propagating pretty well. So something that Connor was mentioning earlier was this concept of viral load, or the amount of virus that is in our various bodily secretions, like our respiratory droplets or our saliva, or sometimes in our feces as well. So that's something we know a lot more about now. So we know, if in a milliliter of saliva or in a gram of poo, how many virus particles there might be. What we still don't know is how many of those virus particles are necessary to start an infection in another person. And no doubt that will be a variable amount, depending on lots of other factors. And we also don't know, as far as I know, correct me if I'm wrong, Connor and Andrew, we still don't know whether exposure to a lot of virus particles in a short time is the same as, or better or worse than, a smaller amount of particles over a longer period of time. So there's still plenty that we really don't know. So that we'll come back to the debate about airborne or not soon enough, I think. But we still need to stick with all of the usual things. So we still need to be washing our hands. We still shouldn't be touching our face, especially when we're outdoors. And we absolutely should be wearing face coverings, especially when we can't socially distance and when we're in contact with people that we normally aren't in contact with. So everyone in your household and so on.
So I want to ask you now about those distances, because you've written a really great article for us about, this concept of a safe distance for coronavirus. And we see that it varies greatly worldwide. In some countries it's 2 meters, in others it's 1, others 1.5. How do we come to these measurements of what is a safe distance from another person to avoid catching coronavirus, and what factors might vary that?
Yes, so I mean, this is basically the distances are sort of arbitrary. They're based on a theory. They're based on theory about droplet size transport. So the idea is that if a droplet is larger, it has more mass, therefore gravity will settle it out of the air quicker. And that means that, if I did a cough, the bigger droplets would settle quicker and more close to me. And then the smaller droplets might be transported further away. And settle later or not settle for long periods of time. But I mean, that's the theory. And no doubt that is right. That's true if you were in a controlled room with no air movements and everything was not like the real world. So in the real world, there are lots of different things that will influence this. And ultimately, you can't just pick one distance and it will be applicable to absolutely every scenario, because there'll be a gazillion and one scenarios. So it's dependent on perhaps the viral load within the infected person. So how many virus particles they're letting off with each time they open their mouth or breathe out, but also on how susceptible other people are within that space, how long a period of time you're spending together, whether people are wearing face coverings, what's the ventilation like? Is it recirculating? Is it just blowing stuff around, which is clearly worse? Is it actually allowing some fresh air in, which is clearly better? And then there's also this whole aspect of being indoors or outdoors. So outdoors, there's a lot of fresh air. There's a lot of air turbulence, all sorts of airflows that we don't really notice very much, other than things like wind, which are on a much larger scale. So yeah, indoor. So my advice would be keep the distance as big as possible if you can. And if you can't, put on a face covering.
That's pretty good. I want to see that on a billboard. Stay as far away as you can at all times. Maybe on a T-shirt. So I'm walking down the street, I can just say, stay as far away as you can. I would love that. Connor, I want to come back to you and talk a little bit more about something that we touched on earlier around asymptomatic transmissions. Can you explain why we are infectious when we are asymptomatic or maybe pre-symptomatic for coronavirus? Because I think, most of us would assume that when you have a lot of symptoms, you would be the most infectious. But it seems in this case, we are seeing a lot of asymptomatic and pre-symptomatic transmission. Oh, you're muted. I should get more.
Sorry. So yeah, the importance of the less symptomatic sort of spread is really a defining feature of why COVID-19 and SARS-CoV-2 is so dangerous, and certainly compared to SARS-1. And yeah, we don't really understand sort of how this comes about, but we know that people who aren't that symptomatic are playing a big role in the spread of this epidemic and pandemic, and we don't really understand the mechanics of it. And I guess you can imagine in your head that if you're coughing and spluttering and sneezing, that has to have some a bigger role. And I think probably it does have a large role in spreading it. But I guess those people who are symptomatic are relatively easy to control and isolate away and separate them out. And it's the asymptomatic people that you can't find, and that makes this so dangerous. And sort of why having lots of virus in your respiratory tract makes you infectious and without symptoms. I think this probably comes down to just from talking and from breathing. There's sort of very small droplets are still coming out, and if you're close by, and that will spread. And also, I guess, from touching and shaking hands and surface spread, there are plenty of ways that the virus can move its way from sort of one infected person's respiratory tract to another. So there are plenty of reasons why asymptomatic spread does occur and why it's so difficult to control.
I want to talk to you now, Andrew, about finding those asymptomatic cases and testing, which is forever a topic that is in the news and was very much in the news in the UK this morning. I know there are debates around the accuracy of these tests and whether they provide, a true picture of how many people in the community are actually positive for coronavirus. Why does this matter? Why does this question of sort of accuracy of testing and finding asymptomatic people matter so much in terms of sort of from a transmission perspective, I guess?
Okay, thanks a lot. I guess let's start with this opening line that there is no such thing as a perfect test. But unfortunately, sometimes we hear the politicians and others say, "Oh, we've got this magic test that will tell you whether you've got infection or not." It doesn't work that way in real life. Every test will give you false positives and false negatives. So in the case of false positives, you have people who have a test that say they've got an infection when they don't. The danger of a false positive is you're going to get an overestimate of the prevalence of disease out there. It might also lead to an underestimation of the fatality of this condition. It generates lots of work for your public health teams who are trying to track, trace, and control the disease. And of course, for patients, it just generates a lot of anxiety for people. And then for the false negatives, and here's where we probably need to be more worried about, you will have people who are falsely reassured. And these folk might be infectious, but have a negative result, and they continue with their daily lives and infect others. So I guess the message really, if you've got suspicious symptoms for COVID-19, but the test is negative, don't assume that that's the case. And get a medical opinion on that. And what determines whether a test has an accuracy? There are lots of factors. It could be down to the test characteristics, how the test was taken, how the test samples were stored, how they were transported, how they processed. And even at the laboratory stage, you could get contamination at any stage of the process, which will give you a false reading. As I'm sure Connor will attest to this. We also get a phenomenon called cross-reactivity with other viruses. So some of the tests we use, such as the PCR test, the polymerase chain reaction test, are very sensitive, but there's always a risk of cross-reactivity with other viruses. And there's also an issue about when you take the test in the stage of a disease for the person. If you took the test too early, you might get a negative result. And if you took the test too far into a person's disease and where the body has perhaps neutralized a lot of the viruses, you might not get a lot of the viral material. Now, why this matters, coming back to your question really, has to do with the interpretation of results, the surveillance results across the country. If you test more, you will find more. That's just it, really, yeah? And in recent weeks in the UK, we've found more cases, partly down to more testing. And a lot of these cases that we're finding are in people with mild symptoms who might not have been tested 3-4 months back, okay? This affects the interpretation as to whether you've got a worsening problem or not. The other thing that confuses matters is that now we have got different tests in place. Previously, we were only using the swab tests, using the polymerase chain reaction tests, but now there are antibody tests as well as antigen tests thrown into the mix. And all of these tests have different characteristics, different accuracies, different yields. The net effect of all of this is that it makes the interpretation very difficult within a country. Never mind trying to make comparisons between different countries, because every country will have a different set of test criteria and testing practices. So I hope you just get a sense of how testing itself can give you a very confusing picture And it's not as straightforward as counting score in a football match, per se.
So we've seen a bit of controversy, as I mentioned, over testing this morning, with Health Secretary Hancock mentioning that, there's people taking tests who are not symptomatic. Would your sense be that more people should be getting tested just to find these asymptomatic cases, or is it more complicated than that?
And for me, I've got an issue with this, because there is a group of folk who believe in mass population testing. But I don't think it's been thought through carefully enough, the implications for that. Firstly, how often are you going to repeat the test? Because you could have a test today, Megan, which shows that you're negative. The very next day, you're going to come into contact with someone who's infectious, who infects you, but you're all right. And 5 days later, you're infectious, but you think you're not because you had a negative test done today. So how frequently are you going to test? The UK has over 60 million people. And if you're going to test on a weekly basis, you can do the maths. You're going to end up with what? 300 million tests you've got to do. No, in fact, my maths are terrible there. It's probably 3,000, isn't it? 3,000 million tests you've got to do. And it just gets astronomical. Coming back to the false positivity issue, there was a government scientific paper that estimated the false positive rate at 2.3%. That means 2.3% of people getting a test result had an erroneous result. And these people would be taken out of schools or taken out of their workplaces and isolated. And it's not just them. It's anyone in their household who's also got to isolate. So you can see how disruptive this becomes. I guess the trouble is people like a magic bullet solution, and they think that, we'll do mass testing. It'll tell us whether I've got an infection or not. It's not that easy, and there are lots of considerations to bear in mind.
Does anyone else want to come in on this question of testing? Because I know it's sort of a live issue right now.
I guess maybe I have a very brief thing to say, that I guess, at this point where kids have gone back to school and we're being encouraged to go back to work, there is going to be more demand for tests, because people want to make sure that they can send their child back to school, or that it's okay for them to go back to work. So I absolutely agree. Ultimately, we don't have the capacity to be testing everyone on a regular basis, but I think we need to be prepared to respond to this higher demand of tests, which is in response to the guidance on going back to school and going back to work.
Well, I've got you. I want to talk about some of the environments that people are going to be finding themselves in at the moment, either at school or at work or what else. You mentioned before this role of ventilation. We also have concerns about things like air conditioning and heating and cooling systems. What role do these kind of factors play in terms of spreading this disease indoors?
Well, there's currently fairly limited evidence on, specific cases or case studies where an air conditioning unit blew some SARS-CoV-2 into somebody's face and then they got infected. There are a few, and there is some evidence of this. Anything we do where air comes out of our respiratory system, different droplets get released into the space around us. And there's a range of sizes, and we've talked about this already. The big ones settle, the little ones go further away. So these little ones that are moving further away from us will be impacted by the ventilation system that's in place in the space where you are. At home, generally, that is just natural ventilation. So we might open a window, we might open a door that lets in fresh air, that dilutes out any respiratory droplets that are around us. In larger buildings, public buildings, such as at work or at school, there are more sophisticated ventilation systems, mechanical ventilation systems, some of which use air conditioning. And with air conditioning, all that we're doing is recirculating air, which is being cooled down or warmed up, depending on the season and depending on what setting they've been put on by the occupants of the room. But then we also have mechanical ventilation where fresh air is actually brought in from outside and pumped into the space. So the difficult thing is that you can have any combination of those things, and you can have some fresh air coming in, but then also being recirculated. Somebody might open a window. So there are lots of complicated scenarios. The main thing is that the more fresh air we bring in, the better, because it'll dilute the potentially virus-laden droplets that are around us. But I guess this is something that's going to become more difficult as we go into autumn and winter, because we're not going to be wanting to open windows because it's going to be cold and wet and horrible. So it's something to bear in mind. And I think, as you know, as much as possible, I think public buildings like offices or buildings where a lot of people are going to be spending time, including schools and other spaces as well, they should really look at their ventilation systems in as much detail as they have the resources to do, and make sure that if there are mechanical ventilation systems in place, they're working as they should be. Because sometimes, you know, somebody puts a cupboard in front of an inlet, and then it's not, it was designed in one way, but it's being used in a completely different way, and then you're not getting what you want.
Mm-hmm. And as a rule of thumb, more fresh air is better.
Yes, absolutely. Not just from the point of view of coronavirus, from the point of view of everything. You know, if you sit in a stale office for long enough, you're not going to be feeling very motivated.
Yeah, fair enough too. I want to come back to this question of whether this virus is airborne, or this is something that's been debated, and you alluded to this before, Lena, and we've seen pressure on the World Health Organization to define this as an airborne disease or an aerosolized disease. For an uninitiated audience, can you just briefly explain what that debate is about and what it means if the coronavirus is airborne? So
I'm a microbiologist, but I work with clinicians in hospitals, and I also work with engineers because I sit in a civil engineering department. So I understand both sides. So an airborne infectious disease is defined in a specific way clinically, because how it is defined has a direct impact on how patients with that disease are going to be treated, both from the point of view of where they're put within the hospital, but also how the staff that deal with them have to protect themselves and so on. And however, there's a continuum of droplet size. It's not like, you know, there are some that are over 10 microns, and then there are some that are under 1, and that's it. There's a continuum in it, and it's not like there's a direct, you know, here is the border and this is airborne and this isn't. So from the point of view of the engineers, they're like, well, you know, this is a continuum. You go, this is just an arbitrary, random, you know, distinction that you've made. So ultimately, I think this is something that we need to iron out across the disciplines. We need to figure out where is this border. And we need to figure out a useful border, because it has implications for care and for treatment of patients, but also protection of clinical staff. So it's a really difficult one, but I think it's well overdue to have this conversation. And I hope that we have it in a civilized and professional and useful way.
We're all about civilized conversation here at The Conversation. Connor, do you want to come in just on this question of airborne viruses from a virological perspective?
Yeah, so I think this is always a really hard question to address for viruses, to sort of build up enough evidence from a virus point of view and a sort of epidemiological point of view that viruses can be aerosolized and survive in aerosols, and then they can be infected. But it is really important, as Lena says. So I think the evidence for this virus is we can find it in aerosols, and we can find evidence using sensitive molecular tests and sort of trying to isolate the virus in the lab, we can find it in aerosols. So very likely it is possible that this virus can be passed from one person to another via aerosols. But I think the question is not can it happen, sort of how important relative to all the other means of transmission is this. And I would probably say that from what we've seen, it's probably close contact is probably the most, one of the biggest risk factors, and that maybe strengthens the evidence that aerosols aren't playing the major role. But again, it is open to interpretation. But I would say on the balance of evidence that they probably play a minor role in spread. But certainly it is a possibility and it should be considered.
Great. And now I want to basically take the same question to you, Andrew, but look at it from a public health perspective. So, how should our understanding of public health guidance or public health measures adapt if we are dealing with an airborne virus, even if it is, as Connor mentioned, sort of not the primary mode of transmission?
Thanks. Well, just to start, I totally agree with Lena. This, in a way, is a pedantic argument because it's not either or, black or white, droplet, aerosol. It's a spectrum. But Lena also makes a very important distinction here. She says that whether it's aerosolized has significance, particularly in healthcare settings. And these are healthcare settings where we know you've got patients with the infection spewing out lots and lots of virus for prolonged periods in a hospital setting or a ward setting, and you've got healthcare staff with prolonged contact with those patients. When we talk public health, we're not talking about healthcare settings. We're talking about outdoors, out in the real world, so to speak, in offices and in schools for the rest of us. And the two settings are not the same. Okay, so the degree of exposure, contamination is less. Whether it's aerosol or droplet, in a way, doesn't change what we do from a public health point of view. The advice is still the same. The analogy I like is to think of aerosol spread as cigarette smoke. And cigarette smoke, the closer you are to the smoker, you're going to smell it. If you are in a poorly ventilated room with a smoker, you're going to breathe a lot of it in. And it's the same. But if you are passing someone in the street who's smoking, you might just get a whiff of it. The chances of you inhaling something, enough of a dose, is probably pretty low. Okay, so that's the first thing to think about it. An environmental health colleague of mine many years ago told me that the solution to pollution is dilution. And that highlights the importance of ventilation. And again, Lena's right. Outdoors, you're looking at a 20-fold reduction in risk if you're outdoors rather than indoors. So if you're going to dine out, dine outside. If you're going to have a drink with your mates at a pub, have a drink outside. Space yourself out. It's that distancing that matters. So today, the British government has put out public health advice to the public, and it's all about washing your hands and covering your face and watching that 2-minute distance. But of those three actions, the one that probably makes the most difference is the distance. So regardless of whether it's a droplet or aerosol, mind your distance. And I guess that's the message to put out, really.
Yeah. And so in terms of how we assess our individual risk, for you, it's about what kind of spaces we're going to be in and for how long. Is that fair?
Yeah. In my mind, there are 6 key factors. The first one is proximity. How close in contact are you with someone else? The closer you get to that smoker, the more likely you are to breathe it in. Secondly, crowds. Because with crowds, you get the proximity factor, but you also increase the risk of coming into contact with someone who's infected. The third bit is confined spaces with poor ventilation. So that bit we know, the 3 Cs. And this is what the Japanese and Americans and others have advocated. But there are 3 other elements as well. The first is duration. The longer the time you spend in that risk setting, you're more likely to pick up something. The second bit is about how much aerosol is being produced. We know that shouting and singing generates 10 to 15 times more aerosol, basically. So you probably don't want to be in a very noisy nightclub shouting your lungs out in close contact with a huge crowd and it's poorly ventilated. And so you can see how the risk factors add up. And the last bit is about personal risk. Looking at the epidemiological studies, we know that the elderly are at higher risk of adverse outcomes. We know that some of the ethnic minority groups have higher risk. We know there's higher risk for bad outcomes for people with some long-term conditions, such as cancer or those who've got immunosuppression, for example. So it's a combination of those 6 factors I would think of when trying to ascertain a person's individual risk or indeed that risk for that risk setting.
Yeah, personally, I'm very sad that this is probably the end of my career in karaoke bars for the next little while, because that seems very, very high risk, unfortunately. Lena, I want to go back to you on this question of schools and offices, because another piece that you wrote for us was about how, really now is not the time to relax on our restrictions when it comes to coronavirus. But nonetheless, we are seeing children going back to school. We are seeing people being encouraged, or indeed in some cases forced, to go back into offices. And as we've discussed, these are not the safest places in a number of ways. So, I mean, what is your advice for people who are going back into the office at the moment and who have children go back to school, in terms of what Andrew says about how we manage our personal risk?
Yeah, it's a really difficult one. I mean, that piece that you mentioned, I wrote 4 weeks ago, just over 4 weeks ago. And at that time, there was about 800 new cases a day in the UK. And now we're, teacher somewhere between 2,500 to 3,000 a day. And I know, testing, of course, I think there is more testing being done. There's more demand for tests. People are worried about, can I send my child back to school? They have the symptoms, they need to have a test and so on. So I think we are testing more and we're finding more cases, clearly. But, it's clearly not over. Cases around the world are off the scale. Well, they're not off the scale, but you know what I mean. It's certainly not going away. And the virus and people are still moving around the world and moving around the country, and with them, so does the virus. So kids have gone back to school, and from personal experience, I have to say, I have a 6-year-old son. It was really difficult having him at home. And I think, psychologically for all of us, it was really challenging. And I do feel sweet relief that he's somewhere now, with his peers, and I think his life is a lot more fulfilling. However, there is a risk associated with this, and ultimately we will see how it goes. From the point of view of going back to the office, I mean, I think ultimately, if you can work from home, you should. We are probably going to see more and more cases in the coming weeks and months, and it's only going to get more and more risky. So better not to make it worse by, going into the office, picking it up, and then spreading it to other people. If you do have to go back to work, I think you need to think about how you're going to be getting to work. Public transport, of course, will pose more of a risk than if you're walking or cycling or taking your own car. I mean, sometimes that's not possible. So sometimes you will have to go on public transport. And if so, make sure you're wearing that face covering and that you're wearing it properly. No noses out, no, fiddling and so on. Wash your hands once you get to your location. Put that mask away and use another one on the way home. And then once you're in the office, just, try to keep away from other people. I know it's difficult, and we've all been at home, and we want to have a chat with our colleagues, but ultimately this will expose us to risk. So if you can't socially distance, if the ventilation system is bad, then you should be wearing a mask. And then if you're, when you're going to the kitchen in communal areas where lots of people will have been touching different surfaces, bathrooms, kitchens, any sort of communal area, just make sure you clean your hands when you get back to your desk. And I mean, I guess that's as good as we can hope for. If you can, if there is such a person within your workspace, ask if somebody can come in and do some ventilation testing to see whether the ventilation is working well. Many large office buildings have facilities managers who should have some idea about how to do this. So, yeah, that is my best advice. I guess the kids have gone back to school, so I'm wary of a lot of measures being eased at the same time. You know, kids going back to school, people going back to work. It's just a lot more risk on top of, you know, one on top of the other, and that is, you know, potentially a recipe for disaster.
Yeah, I think it's something that we're all grappling with, and you know, I think there's some very solid advice in there. And for any employers listening, I think the message is to make people go back to the office if they don't have to.
Could I make a point, Megan?
Yeah.
And it's about children, really. I think as a society, we need to be mindful of the risks and benefits and harms to children. We know that for young children, the risk of getting coronavirus and dying from it is extremely low. It's something like 1 in a million chance. It's extremely low. We know that the risk of them transmitting from a young child to young child, again, is fairly low. It appears more from the epidemiological study, it's a case of adults passing it to children. It's very different, I guess, when you're looking at older children who are teenagers approaching adulthood, where the risk will approximate the adult for transmission. But if you look across the world, to China, to Taiwan, Singapore, Hong Kong, they've got schools back going. They've had schools going for months now, and they've done it successfully without large outbreaks. And I just find it, well, strange, really, how much angst we have, especially in the UK, about kids going back to school. So the risk isn't necessarily to the child from COVID, but the risk of missing out on education and all the mental health and well-being issues, that's considerably more.
Yeah, I think it's possibly on the adults to behave so that we can allow kids to have the mental health benefits and the educational benefits and just the all-round general benefits of being with their peers and being in school and learning. I want to ask one last question of you guys before we turn to some of our viewer questions, because we have a lot of those that I want to get to if we can. I want to start with you, Connie. You kicked us off today by talking about sort of everything we've learned since January when this disease first emerged. For you, in your line of work as a virologist, what are your big questions that still need answering about the transmission of SARS-CoV-2?
So I agree that, you know, understanding the transmission of these viruses is so critical. But I think this is just sort of you've got me thinking about SARS-CoV-3, COVID-41, and I think we really need to understand, you know, what makes these viruses transmit so well. Where are they? Sort of where in the world are they, and where are they most likely to move from animals into humans? So I think this is you know, SARS-CoV-2 is done sort of in my thinking, and we have to start thinking about the next big one. So I want to leave everyone with that chirpy thought around that. But yeah, certainly that is trying to understand a bit of the virology around that, and an ounce of prevention is going to be really important for the next big one.
Yeah, and that's we're counting on you, Connor, to find that for us, please, in your lab. But seriously, do you think? I mean, should we have seen this one coming a bit better, or was it sort of one of those unknown things?
Well, this is SARS-CoV-2. You know, we knew SARS-CoV-1. There's a lot of respiratory coronaviruses in humans. You know, we were looking out for this one. We were actively searching for coronaviruses, specifically SARS-related coronaviruses, and we did not see this one coming. So I think, you know, something's got to change. Either we're looking in the wrong places, we're not looking for the right things, and likely, you know, we don't really understand, you know, how these viruses transmit and why that's so important. So that might have sort of led to us in missing it a little bit, but we were actively looking for it.
Well, like I said, if you could keep looking, that would be great. Well, Lena and Andrew and I work on the pandemic that we currently have. So I want to go to some of our viewer questions now, because we have a few that I'd like to get to. Here's our first one from Bernadette. Why does our government just do one thing only? All back to school, then open nightclubs 4 weeks later. Is there a better way to understand the spread of the virus? And Lena, you've touched on this a little bit already, so do you want to take this one?
Yeah, I think it's a way of mirroring the scientific method. So it's trying to control all factors but one to see what's going to happen. But clearly, it's not as simple as that when you're dealing with a whole population of people, all with different priorities and needs and so on, as opposed to, you know, something that you might be doing within the lab. So yeah, in my thinking, it's a sort of, let's ease one thing and see what happens, and then if it's not too bad, we can maybe ease something else.
Mm-hmm. I think that's pretty clear. We'll go to question 2, which is a question that lots of people have about how effective cloth masks are, that a lot of us are wearing, these kind of reusable, washable masks, and whether airing or ventilation in classrooms might be better than masks. Andrew, do you want to take this one on about the effectiveness of different masks in different settings?
Sure, thanks a lot for that. So firstly, the way masks work, whether it's a face covering or a surgical mask, is what we call source protections. And what that means is if I've got coronavirus, I'm wearing a mask, then I'm trapping the virus within me, and I'm not spewing it out at you. Yeah. So let's be clear about that. So it's about stopping me infecting you. And there have been some studies and modeling studies carried out that have shown that face coverings do help. Yeah. And the figures are up to about 60 to 75% effective compared to a surgical mask. That's not bad, pretty good. And the way to make it better, make sure you have triple layers and different materials in your cloth mask. So they do work. But ventilation, as we've heard, is important. And I want to leave Iris with a thought here. Okay, again, something so dangerous. Do we only want one level of protection? It's probably better to have multiple levels of protection. Have the face mask, have the ventilation, have the distancing and hand hygiene and so forth. Because all these different measures that we take are additive, and the additive effect protects us all.
That's great. What have we got next? Okay, this is from Louise. What is the latest evidence about transmission between children in schools and then on to vulnerable parents, teachers, and grandparents? The evidence from around the world seems conflicting. We've touched on this a little bit. Connor, do you want to take this one on about intergenerational transmission of this virus?
Yeah, so we know that this virus can spread, or it can infect sort of anybody of any ages, and the risk there then that it can spread onwards. And we know that sort of the younger you are, the less likely you are to get sick. So again, the risk isn't really on the child, as Andrew said. It's more on the vulnerable people, sort of near the child, and also in their role in spreading it to other people. And certainly that this can happen. Children can spread it, adults can spread it to children, children can spread it to each other. And again, it's all about how common does this happen? And the evidence it is kind of conflicting. We don't really have a really good understanding of this. I mean, some of that is because the studies haven't been done in an environment where there's lots of transmission in the community. If you look at places in East Asia, they have got really they've controlled their community spread. There's not a lot of virus there, so there's not the chance of it getting into a school is going to be very low. So we can't really do those studies. So there is a gap in the evidence, and sort of evidence of, or absence of evidence is not evidence of absence. So we need to be really careful with this, but certainly it can happen. So yeah, we just have to sort of be mindful of that, but we have to sort of protect, as Andrew said, protect kids, allowing them to get back into school. And one way we can sort of stop that is controlling the spread of the virus outside of schools and the community.
Sure. Like I said before, adults behave. So here we have another one. What is the role of heating systems in winter in our homes? So we've talked a little bit about air conditioning, but what about heating? Are they dangerous? Lena, you're our sort of engineer adjacent person. Do you want to take this one on?
Yeah, of course. I think within the home, ultimately, I don't think any sort of HVAC, so heating, air conditioning, ventilation systems are really an issue, because ultimately they're just blowing around the things that you're leaving in the environment. Sorry, I'm bleached by the sun. The sun has come out in Essex in the afternoon. Yeah, so I think at home it's not an issue. However, at work, a lot of the heating systems will be based on a sort of air conditioning type scheme where air is recirculated and then it's heated as it goes through the system. So if it is a recirculating system, then that could be an issue. But heating in the home or any sort of, aircon or ventilation in the home really shouldn't be an issue unless, an infected person comes in from outside the household.
That's important. So even sort of aircon within your own home is going to be a lot safer than aircon in an office.
Yeah, it's all about what is it that it's blowing around. So it's just blowing around your own stuff, then that's fine. But if it's blowing around somebody else's cough into your face, then not so good.
Not so good indeed. Okay, well, look, we are basically out of time. So I just want to say thank you to our panelists. You are all fantastic. And I hope this has answered some of the questions that our viewers have. It's certainly answered a lot of questions that I have and also inspired some T-shirt slogans about what's that one about dilution is the solution. Definitely want that one. And the one saying stay away from me would be great too. Maybe that's something we can look into at the conversation. But yes, excuse my digression. I really want to thank you all, Lena, Connor, and Andrew. Thank you so much for joining us. Thank you to our viewers for tuning in and for asking such fantastic questions. We're going to be doing more of these discussions as this pandemic rolls on. So do subscribe to the newsletter of the conversation and you'll be notified of those as they come up. And you can also keep up with all of our latest articles and views from academics all around the world. Thank you again, everybody, for joining us, and we hope to see you next time. Bye.